So I'd just like to introduce the first speaker this lunchtime is Ajith Dissanayake, who we all know very well as one of our endocrinologists here, is going to present a case for us.
Right.
You have to use that, apparently.
All right. Thank you. Right. So years of hard work could be studying for exams. It's not. Commonly, we diagnose patients pretty promptly and treat them adequately, and there isn't much of a delay in our hospital, unlike other hospitals. But occasionally you come across patients where it takes many moons to diagnose, and then even if you diagnose them, then to have a proper treatment plan, it takes years to establish. So this is one of those cases, quite exotic and small print medicine, if you like. So this woman, 41 years, she is originally from Philippines and came to New Zealand about 20 years ago, married with 3 children, accountant, and was absolutely physically fit. And she used to run and she used to walk quite a bit. And she used to do round the bays every year for about 10 years. But in 2004, problems started. And she had aches and pains of insidious onset, and multiple sites were involved. And initially, she was seen by many doctors, including a rheumatologist, who thought it's musculoskeletal, and possibility of fibromyalgia was raised. And it's a common diagnosis by rheumatologists anyway. And then she took that advice and bought a book on fibromyalgia and started doing some Pilates, because that's what the rheumatologist recommended. Anyway, late 2004, she found that she was suddenly becoming quite weak and difficult to climb stairs, extremely fatigued, and couldn't cope up with her usual day-to-day life. The GP started on some nortriptyline, but with minimal effect. Now, she had heaps of tests. Now, these are the salient ones. There was mild elevation of alkaline phosphatase. She wasn't pregnant. With a normal GGT, points to a bone issue rather than a liver issue. The serum phosphate was moderately reduced. It's not uncommon in South Auckland. In people who are obese and has type 2 diabetes, with HbA1c is more than 10%. You will generally see this type of phosphate levels anyway, due to polyuria and losing electrolytes. But this is different. And her vitamin D was slightly subnormal, which is again not uncommon in Asian population. And she had a normal parathyroid hormone. So there was some suggestion with the aches and pains and inability to move very much, there's something going on. So she had a bone scan. So this is all in 2005, later on. Now, if you look at the bone scan, is there a pointer here? Probably not, right, okay. Obviously, if you look at the one on that side, you can see multiple hot spots, which is quite alarming. And the first thing that it comes to your mind is whether this woman has breast cancer with metastatic lesions. But given that she was so well and breast examination and mammograms were unremarkable, you need to think of other conditions such as osteomalacia. There was no family history of similar illnesses. She had three children, and the 10-year-old youngest girl had 3 fractures before. It's considered to be post-traumatic. I'll come to that later. And she's not an ethanol consumer or didn't have any evidence of diabetes to explain reduced phosphate. Exam was unremarkable, except that she had tender spots everywhere. And of course, she had proximal myopathy on examination, and neurology was essentially normal. So these are the other tests, the salient ones. CRP was 1, and alkaline phosphatase is moderately elevated. And serum phosphate was persistently reduced. And a tubular reabsorption of phosphate is a test that we do to assess the phosphate excretion, and was considerably reduced here, which indicate that she was actually losing lots of phosphate through the renal tract. The other tests were that 125 cholecalciferol level was in the lower normal range, and there was no evidence of amino aciduria or glycosiuria. Now, these are the tests that we do to rule out the possibility of acquired or hereditary Fanconi syndrome, where you can get amino aciduria, glycosiuria, phosphaturia, and you get similar kind of weakness. So there wasn't any evidence of that. And subsequently, she had a bone biopsy, which showed evidence of definite osteomalacia. So she was clearly osteomalasic. And we had an opportunity to investigate the daughter, and because she had some fractures, and she had normal chemistry, normal phosphate, and normal phosphate excretion. So that, therefore, all in all, this woman most likely had osteomalacia, and there was no element of hereditary etiology to consider, because the woman's relatives were okay, and the child didn't have any evidence of hereditary elements. So, what's the diagnosis? So by process of exclusion, it has to be oncogenic or tumor-induced osteomalacia. And this was further supported by an estimate of fibroblast growth factor 23, which is classically elevated in this condition, and I'll come to this point as well later. Right, now, prior to scanning and finding where the culprit lesion is, which is usually very small, we started her on treatment. So you replenish 125 with 125 cholecalciferol and phosphate sandose. They're nasty drugs. Phosphate sandose, if you take, and it definitely causes diarrhea and abdominal discomfort. So there were initial problems with actually managing her with medications. And several times we had to adjust the dose of medications. And ultimately, her levels were reasonable, and we were able to have an excellent clinical response with normalization of chemistry. Right, now, this is a MRI turbo stir image, which is a screening test, which we do to detect the culprit tumors, which are generally very small. Now, unfortunately, there's no pointer here, but I'll probably point from here. Now, this is a coronal view, and if this is her left hip, left femoral head, and if you look closely, there's a little dot here, which is a small, tiny dot. Given that she had osteomalacia and several other areas been lit up, this is kind of overlooked, or the comment was that this is probably a little focus of fibrosis rather than anything significant. Now, this is a dedicated CT scan done a few days later, which again shows a very tiny lesion, which is considered as a sclerosed area. And the dimensions were very small, about 0.5 centimeters in diameter, so 5 millimeters in diameter. Now, this is 3 years later. Now, during this period, she was on medications with every 2 months blood test to titrate pills. So GP was very helpful to do that, because we can't sort of see them every 2 months in a clinic. And then certainly if you look at this lesion now, certainly it looks slightly better, slightly bigger than what it was, and the dimensions have gone up to about 7 millimeters. By the radiologist and general discussion that we had with clinical endocrinologist in Oakland was to say that, look, this may not be it, this may be just a fibrosed area, and we might as well observe her rather than act, because she was so well and managed very well on medications. Now, this is, she had lots of x-rays, and this is one of the x-rays done in 2011, last year. And you look at it very closely, you probably can see some sclerosed areas, generally bilaterally, which is reported as mild osteoarthritis. And you actually couldn't see a tumor of any nature here by a simple x-ray. Now, she subsequently had another turbo imaging MRI, that's about 3 years later in 2011, which showed that the lesion was much more conspicuous. So we got a bit worried at this stage, there is something there, and the dimensions are about 1.5 centimeters. It's almost doubled in a period of 3 years. So it's slow growing, definitely, and pretty confined, and doesn't look like a malignant lesion. It looks pretty much like a benign lesion. So at this stage, we wanted to further investigate and had a dedicated CT scan. Now here, if you look at it, you actually see a quite different lesion here. You can see a sclerosed area around and a more homogeneous, dense area in the center, which is different to the one that we did about 7 years ago. Now, this is again interesting. This is a bone scan again, which is done at the same time of the last CT scan. And you can see a considerable resolution of those hot spots, which means that they were really osteomalacic lesions, and now they have subsided as a result of treatment. So we were kind of happy about that bone scan. Now, this again, side by side. This is the first bone scan, which showed multiple lesions which were not there in the second one. Now, these are the 3 turbo images side by side. This is the initial one, which shows a tiny lesion, a slightly bigger, and a little bit more bigger on the third one. So 2004, 2008, and 2011. Now, this is a state-of-the-art kind of scan, which is done in Sydney Cancer Unit, which is gallium-69 dot-rate PET CT scan. We don't have this facility here. They were quite good people and gave us a good price, about $800, which is probably much cheaper than a PET scan in Auckland. And if you look at it, there's pretty pictures, and actually you can see very nicely the lit up area. And typically, with this compound, mesenchymal, tumors of mesenchymal origin are well lit up, and you can actually visualize them very well. This is again a dedicated CT, which is done at that stage, which clearly showed the lesion has been bigger, a sclerosed ring, and a central area of homogeneous opacification. Again, side by side, the 2 lesions, the previous one and the current one, a difference of almost 10 years. Right, so a few things about oncogenic osteomalacia. It's a rare neoplastic syndrome. It's usually a benign mesenchymal tumor, and commonly somatostatin receptors are positive. You've got to have a somatostatin positivity to be detected by these scans by fluorescence. So if they're negative, then it's very hard to detect. And a small percentage of tumors which cause oncogenic osteomalacia are somatostatin negative. And typically they are very slow growing, therefore the symptoms are very vague and take time to diagnose. There are 357 case reports till last year, and we published one in 2004. And at that time, there were only 20 publications. And there was a sudden influx of publications afterwards. The reason was that it was in 2006 that the actual phosphaturic substance was identified as FGF23. So it's the FGF23 effect that causes the syndrome. Right, so the chemistry, classically hypophosphatemic and with evidence of renal phosphate wasting. 1,25-hydroxyvitamin D is lower than expected, and you see an elevation of ALP as a result of osteomalacia, and the parathyroid hormone levels are classically normal because serum calcium is not altered in this condition. And production of a phosphaturic hormone, which is FGF23, is classical because that's the substance which causes the syndrome. And this was detected as late as 2006. The mechanism, in the simplest form of a way, is that it decreases renal expression of sodium phosphate co-transporters, thereby causing phosphaturia. And it also decreases the expression of 1-alpha hydroxylase, which is necessary for formation of 1,25-hydroxyvitamin D. So therefore, there's a deficiency of vitamin D in circulation, active vitamin D. I wouldn't go into detail on this complex topic, but in a nutshell, these are the hereditary syndromes, where again it is due to either elevation of FGF23 or the cleavage of FGF23 is affected to an extent that you have elevated biological activity of FGF23, thereby causing the syndrome. Imaging technique, magnetic resonance turboimaging was the state of the art in the days gone by to detect these tumors. But once you get a suspicious lesion, then you have to have a dedicated CT or MRI, ideally a CT because orthopedic surgeons like CTs, and to assess the lesion. And the PET CT imaging has become the state of the art nowadays, and 68 gallium dotatate PET CT has got a sensitivity of 82% as against 66% with this other substance. And whenever the somatostatin receptors are positive, they're likely to be detected. There again, the pictures. So treatment. Medical, obviously, the problems with medical treatment is that it has side effects, and you need to sort of titrate it very carefully. And as the tumor grows and the FGF23 concentration goes up, then there'll be difficulties in treating. The only good thing about it is most of these tumors are benign rather than malignant. And surgical treatment is the best provided you can identify them. And it's only about, large series have shown that it's only about 65% of these tumors can be identified. So there are years and years of periods that you have to keep these patients under surveillance. The one we published in 2004, we had to follow that person for more than 10 years. And subsequently, that person had paraparesis. And at that stage, a dedicated MRI revealed that she had a lesion in the spinal cord. And the lesion was removed, and she recovered. So it takes a long, long time to detect these ones for the simple reason that it's spawn. And nowadays, CT-guided procedures with either cryoablation or radiofrequency ablation has been conducted, which are effective. Cryoablation with ethanol in combination is considered to be better than radiofrequency because it causes less pain and less discomfort. But most of the experience is with radiofrequency ablation. So back to our patient. She had a procedure this morning, which is the most exciting thing. And that's the first time that they've done this procedure in this hospital, and there were lots of radiologists, anesthetists, and people watching it. And the radiologists who did the procedure thought the procedure went on reasonably well. And the tissue was collected for histology and for immunohistochemistry for FGF23. And a blood sample was collected for FGF23 as well. So we are looking forward for a huge dropout from those levels. We would expect the immunohistochemistry FGF23 to be very high than the blood chemistry. That's the expectation. And follow-up tests are important to ensure that there is good resolution. It's pretty easy to follow them up. All what you have to do is stop medications and do their serum phosphate levels and an occasional FGF23 to assess. Thank you.